Thanks so much, Roxana, for that nice introduction and for inviting me again to be part of this wonderful meeting with so many live cases and interesting talks and discussions. These are my disclosures. And this is an outline of what I'd like to cover with you in the next 10 or so minutes. What is the prevalence of small aortic annulus? Is it an important entity? Why is it important? What are the implications of that for prosthesis patient mismatch or PPM? Some of the surgical approaches to avoid PPM, and then incidents and implications in TAVR with some discussion of the conflicting ideas, discrepancies. Can we close that? Discrepancies in measurement, calculation, implications, and whether it can be avoided by valve prosthesis choice. So this is some data on small annulus. It occurs in anywhere from 20 to 40% of surgical series. In the middle there are the randomized trials. So these are the two intermediate risk trials with SAPIEN and with Evolute, and the low risk trials with SAPIEN and Evolute. Patients who had a small annulus in the SAPIEN trials was about a third, and in the Evolute trials about a fifth. So it's not an uncommon entity. It's higher in Southern Europe and Asia, higher in TAVR and SAVR, and highest in women, who make up about 90% of the small annulus population. These patients are at particular risk for adverse hemodynamics and prosthesis patient mismatch. This was, of course, an entity first defined by Ramatula in 1978 to describe the mismatch between the hemodynamics of a valve prosthesis and a patient's requirements for cardiac output. And it's calculated as the effective valve orifice area divided by the body surface area. And we have data in the surgical world for decades showing that if you have severe PPM, there is higher mortality, less functional improvement, and other adverse events that I'll show you in a moment. And in the transcatheter world, there's been some controversy about this because we know TAVR valves have a larger effective orifice area than similar surgical valves, but most of these studies have been small series or with limited follow-up. So severe PPM after surgery in a meta-analysis was associated with a 6-fold increase in cardiac mortality. You have worse coronary flow reserve, less LV mass regression, impaired exercise tolerance, less improvement in quality of life, and an increase in structural valve deterioration. There are surgical solutions to avoiding PPM, but they're underutilized. Some of them are complex operations. The more recent, simpler Yang operation has gained some favor. But in general, if you look in the STS database, they're utilized in 2 to 4% of patients, despite the fact that small annulus is probably 20 to 30% of patients. And that has to do with the risks of these root enlargement operations, longer bypass time, increased bleeding, and in some series, more mitral regurgitation as one affects the anterior leaflet of the mitral valve. So what about TAVR? In the early generation devices from this editorial by Philippe Pibereau, you can see severe PPM occurred irrespective of device in 10 to 15% of patients and was associated with an increase in mortality. More recent studies, including the CHOICE trial in second and third generation valves, has not shown a decrease in the incidence of severe PPM, if anything, an increase, as we've put more wrappings around the outside of the valves to prevent paravalvular leaks and not done that at the expense of an increase in valve size. Data has shown that severe PPM after TAVR is a bad thing. This is from a single center Spanish study. Severe PPM occurred in 6% and was associated with more death, stroke, and heart failure hospitalizations. Single center Italian study, severe PPM 6.5%, higher rate of cardiovascular death, MI, and stroke at 5 years. Here, the largest study to date, the TVT registry study that we did, looking at over 60,000 patients, hazard ratio of 20% increase in mortality at only 1 year after adjustment for 34 variables, which we could do based on the large size of this analysis. And you can see the curves, if anything, look to be diverging. And a most recent meta-analysis published in over 80,000 patients, incidence of severe PPM 11%, a 25% increase in 5-year mortality. So one of the questions that comes up is, why is there any controversy about whether severe PPM matters after TAVR? It seems like the data is pretty clear. This is from a white paper based out of the Heart Valve Collaboratory webinar that we did about a year ago. And these are some of the reasons for the discrepancy in the effects of severe PPM on outcomes. Some of it has to do with how one calculates effective orifice area. Do you measure it, which includes the effects of flow, or do you predict it? Although the prediction also comes from echo-derived parameters that include flow at 30 days, and then you're applying a general number to an individual patient. I'm not sure that's any better. The definitions have varied over time. There is a correction for obesity in the latest documentation, which lowers the calculated incidence of severe PPM, but it's based mostly on theoretical reasons and one small study. Not sure that we should be correcting for obesity. The timing of measurement. If you measure it immediately after the procedure hemodynamically, you're looking at the effects of low flow as well as the effects of valve adaptation. Echo versus hemodynamics we'll come back to in a moment. And then some of the reasons why the effects of severe PPM on outcomes are conflicting may mostly be related to underpowered analyses with very limited follow-up. There are reasons for discordance between echo and hemodynamic measurement of bioprosthetic valve function. Both have flaws. Echocardiographically, you can underestimate the gradient, and you utilize the simplified Bernoulli equation, which may not account for several things, including the fact that it's not corrected for pressure recovery. Hemodynamically, you can also have errors. You're using fluid-filled catheters. You're using a pigtail that averages over several distances with side holes. As you saw in the live case this morning, you can have a negative gradient because you're not correcting for systolic augmentation and time delay if you're utilizing a radial arterial catheter or a femoral sheath. And then the timing of measurements is important. This is one of several studies that looked at the time of measurement on gradient determination, and you can see that at day 0 compared to day 1 and day 30, the gradients are always lower right after the procedure, and that's true for SAPIEN as well as for Evolut. The difference is greater with SAPIEN, and it's also greater in small valves versus large valves. And it has to do with two things, not just the flow characteristics. So the LV VTI goes up between day 0 and day 1, but the aortic VTI also goes up, and the DVI goes down. And I believe that that has something to do with the valve adaptation, that these valves are not functioning quite normally immediately after the procedure. Maybe the leaflets are stiff, maybe there's some recoil between day 0 and day 1 in the cages, but the valve itself has a larger effective orifice area immediately after it's deployed. When we look at the predictors of severe PPM, they include female gender, valve-in-valve procedures, and small annuluses. A recent study from the France TAVR registry just presented at TCT looked at third-generation valves in small annuli. The severe incidence of severe PPM was 8% in the balloon expandable valves, 3.5% in the self-expanding valves, a significant difference. And the presence of severe PPM was associated with a twofold excess mortality at 3 years. If we look at women, here you see some partner SAPIEN 3 data showing worse outcomes if you had severe PPM in women that was not present in men. This is not a randomized comparison. And also with SAPIEN, the incidence here in this study was 9%, and it went up if you had low flow, predicted by stroke volume index, and it was associated with rehospitalization in all patients and cardiac death in the low flow patients. We showed in the early first partner analysis of partner A that low flow was a risk factor for worse outcome, whether it was after TAVR or SAVR. But importantly, after you place a valve, flow doesn't normalize in everybody. It does in about 2/3 of patients, but there's about 1/3 in whom it does not normalize, and these patients have a higher mortality during follow-up. So both flow and PPM may be independently important, although we couldn't analyze that from this study. A very recent echo study from the 3 core labs looked at the effects of flow and demonstrated small differences in the low flow patients in terms of gradient reductions. They were lower, and also in effective orifice area. Here you just see SAPIEN 3, 1.5 versus 1.4 if the flow was low. Small differences, no difference in the DVI. And although these are important, mostly what we're talking about are large gradient differences. And in this study from the Australian Echo database, gradients greater than 20 had an increased effect on age and sex-adjusted 1-year mortality, as well as 5-year adjusted mortality, where it was 50% higher if you had a mean gradient greater than 20. In fact, that's also may explain some of the difference that was shown in a recent analysis from the self-expanding registries that Mike Reardon presented and is in press, looking at hemodynamic structural valve deterioration over time. And you can see, even though there were only small differences in gradient between the surgical valves and the TAVR valves, there was a significant difference in structural valve deterioration that was accentuated in the small annulus population, was associated with a twofold excess mortality, and validates the concept of using Doppler-derived measures as a predictor of hemodynamic structural valve deterioration, as well as subsequent mortality. So that comes to the last question: are there differences between prostheses that might influence this? And in this slide that I borrowed from Olda Backer, you can see one of the impacts that we don't talk about much is where the commissural posts are. In the sapien valve, they're inside the cage. In the evolute, they're on the outside of the cage. And that allows for part of the reason for the better hemodynamics of the evolute valve versus sapien valve in the same sized annulus. And that's been shown here in the echo core lab analysis that was done of 3 core labs looking at the smallest quartiles of annular dimension, where balloon expandable valves had a smaller effective orifice area, a larger gradient, and a lower DVI. And again, these gradient differences are relatively small, but they are reproducible. And here's another example looking at the hemodynamic effects of those gradients. This is a study that Lance Gould did looking at stress flow increases with dobutamine, utilizing invasive hemodynamics. These were pressure wire measurements showing that there is more loss of the driving pressure across the LV from 1.0, essentially a fractional flow reserve across the valve with sapien, than there was with core valve. And although these differences are relatively small for the mean when you include large numbers of patients, when you look at the tail ends of the bell-shaped curves, they're more important. So this is, again, TAVR valves versus surgical valves, mean gradient difference of about 3, but the incidence of a mean gradient greater than 20 was 4-fold higher in the surgical valves. The incidence of severe PPM also 4-fold higher in the surgical valves. So that's the rationale for the SMART trial. This is the first randomized head-to-head trial comparing Medtronic's Evolute Pro Plus versus Sapien 3, Sapien 3 Ultra. I have the privilege of chairing the study group along with Roxana and Didier Cheche. This is a randomized trial in patients with a small annulus, 1-to-1 stratification, 700 patients at more than 90 sites, 2 co-primary endpoints: death, disabling stroke, and rehospitalization for heart failure, a non-inferior endpoint at 1 year, and then bioprosthetic valve dysfunction, which includes severe PPM, valve thrombosis, endocarditis, and other and severe PPM as well, gradients greater than 20. And it's powered for superiority of that second co-primary endpoint. And this study is now fully enrolled and in its follow-up phase, and hopefully in a little over a year, we will have some answers from this important study. So conclusions: suboptimal hemodynamics, high gradients, severe PPM, and low flow are all associated with adverse outcomes, including mortality, heart failure, rehospitalization, and valve durability. The subsets of patients that are most at risk for these suboptimal hemodynamics are small annulus patients, which are mostly women, patients with low ejection fraction and low flow, and younger patients who are more active. Does valve selection matter? I believe that the data to date suggests that it does, but the randomized SMART trial will provide us with additional data in this regard. Thank you.